The broadcast is now starting. All attendees are in listen-only mode.
Hi, everyone, and welcome to the Children's Cardiomyopathy Foundation's presentation of Pediatric to Adult Care Tools for Transitioning. My name is Cindy Andrick, and I am the Manager of Family Support here at the Children's Cardiomyopathy Foundation. We're really happy that you can join us today. Before I introduce you to our presenter, I just want to review a few housekeeping rules during the webinar. If at any time during the presentation you have technical issues, please type your concerns into the chat window on your control panel, and we will do our best to address them. If you should have any audio issues or difficulty hearing, you should be able to switch from your computer screen to a call-in phone number to correct the audio issues. In order to provide the highest quality webinar session and to avoid any background noise, all of the attendees will be in the listen-only mode. We encourage you to ask questions during the presentation, and we will reserve the last 15 minutes of the hour to review those questions. Questions can be submitted via the question box located on the control panel on the right-hand side of your screen. Submit your questions by typing them to the question box, and I'll read them out at the end of Dr. Reardon's presentation. If the control panel is preventing you from seeing the screen, you can hide it by clicking that orange arrow, which is at the top left of the control panel. Last, we are recording this webinar presentation and we'll post it on our YouTube channel, CCF Heart Kids, for anyone that would like access to this recording later. So with that complete, it's my pleasure to introduce to you today our presenter. Dr. Leigh Reardon is an assistant clinical professor of medicine and pediatrics. He completed his combined medical and pediatric training at Cedars-Sinai Medical Center, followed by fellowships in pediatric cardiology and adult congenital cardiology at UCLA. Dr. Reardon is the director of the Pediatric Mechanical Circulatory Support Program and of the Transitional Cardiac Care Program. He is actively involved in both the pediatric and adult heart transplant programs, focusing on transplantation in complex congenital heart disease patients as well as transitional care. Dr. Reardon is recognized as a Los Angeles Weekly Superdoc and has received the UCLA Award for Teaching Humanism at the Bedside. In June, he received the Golden Heart Award for Outstanding Teaching in the Pediatric Cardiology Fellowship Program. I want to thank Dr. Reardon for being with us today. We're so pleased that you can join us, Dr. Reardon, and we're really looking forward to your presentation. So at this point, I am going to turn my screen over to Dr. Reardon, and he will start his presentation.
Thank you so much for the very nice introduction. So I'm just going to go ahead and get started and go through things, and then hopefully we'll have some time for some lively discussion at the end of the webinar. All right, so I'm going to focus in on the cardiomyopathy patients and how to transition them from pediatric to adult care, and give you sort of an overview as well as some tools about transitioning your own children, or seeing it from the provider's perspective about what types of tools we're trying to implement and some of the strategies we're trying to implement. I usually start most of my medical talks with a disclosure. It's common practice to discuss whether or not you have any financial relationships or anything. I do not have any financial relationships. And I have some photos in this talk that include a couple patients, and all of these photos are used with permission. One of the disclosures that I usually start off transition talks is actually showing a photo of me, because I got into medicine because I actually had heart surgery when I was 5. I had a condition called pulmonary stenosis, and you can see right here, this valve was narrowed, and I required surgery at the age of 5. It was in the 1970s, before we had a lot of tools to correct this sort of particular defect. But I bring this up more because I think my mother was the ultimate transitioner. I grew up in Albuquerque, New Mexico, which is a smaller town, and in New Mexico, at least at the time, you could get your driver's license at the age of 14, which is quite frightening to most people and myself when I actually think about it. But my mother at that time placed empty checks or blank checks in a specific drawer in our kitchen and made them out to the different doctors that I had. And she said, if you ever need to go see one of your doctors, just let me know how much I need to put in my check register. Whatever you say to them or have conversations with them, I'm always here to listen and to provide support. But if you want to keep that private, that's up to you as well. And I think the fact that she decided to give me some autonomy and made it clear to me that my own health was a priority was really such an insightful thing that I look back now as she was way ahead of her time in so many ways. It's interesting, I went through most of my medical training without having ever disclosed my heart condition to most of the people who were training me. And then shortly after I became faculty at UCLA, I was asked by the people who write the UCLA magazine if I would share my story. I thought this would be an interview, but in the end, they asked me to write it myself, which was a little bit daunting. And one of the things that I found is that a lot of people who are in medicine were really motivated to go into medicine because they had a personal experience. And at some point, I think when I was applying for medical school, I think I decided that maybe it was a limitation and that people would see that the reason that I got into medical school was because of my experience. But really, it was a really beautiful gift. And again, I always have to thank my mother for really being ahead of her time in terms of transitional care. What we've learned in the medical system over the past decade and even before that is that there's just a lot of people now who have chronic childhood conditions that now require lifelong care. And a lot of that has to do with the fact that we have gotten so much better at treating really complex conditions that otherwise in the past, a lot of people wouldn't have survived into adulthood. And so there's really a tidal wave in all the specialties in pediatrics of patients who are transitioning from the pediatric side to the adult side. And the amount of resources and the amount of need is really profound. And I think we're starting to learn that there's so many opportunities for patients and individuals to get lost in the system between the pediatric realm and the adult realm. And I'm going to discuss some of the things that may play into that throughout this next 45 minutes or so. The popular media has actually picked up on this as well. You'll see in a lot of periodicals coming from health systems where they're really focusing on transition. The Wall Street Journal had something in their publication not too long ago about the importance of transition and just making sure that individuals are cared for in an appropriate way by providers who are sensitive to the specific needs of patients as they're going through adolescence and young adulthood. One of the things that I find and I've observed in my pediatric practice is that oftentimes patients have a very critical moment during their earlier lives that results in the implementation of medical therapies, and then they often have very long stable periods, and they're just waiting for the next sort of medical sort of ripple or speed bump in their lives. And it's very easy sometimes to be very joyful about stability and forgetting to move forward with transitional type of intervention. So I thought it'd be worthwhile just sort of starting from a basic definition so that everybody is on the same page and so that you can appreciate how the medical community defines transition. And this comes from the Society for Adolescent Health and Medicine, and they define transition as a purposeful planned process that addresses the medical, psychosocial, and educational/vocational needs of adolescents and young adults as they move from a child-centered to adult-centered healthcare system. Now we're going to come back to the differences between pediatric care and adult care in a few minutes. The way that these training programs are really set up for pediatrics versus adult medicine have very different slants on how they perceive the way that they should deliver information and empower patients. And it really can be translated into people feeling like there's a little bit of a vacuum from when they transition from the pediatric realm to the adult realm, and maybe once they get over to the adult side, still yearning for some pediatric type healthcare. So we like to really work from evidence in the medical field. We like to have good studies that support what we do, that really justify the types of interventions that we're doing. And there's actually something called the Cochrane Library that's freely available online, where they try and analyze the value and the quality of data out there for different types of conditions. It can be a very useful tool even for patients to look at on occasion, because they sometimes can synthesize the information that's out there. And unfortunately, what the Cochrane database does is they look through everything. What they found in the review of transitional care is that there's very little evidence about what we do. And so a lot of what we recommend is based on what we call consensus, where expert panels of people come together and come up with recommendations about how to move forward with particular interventions and with the ways that we approach patient needs. So the Cochrane database basically said that if you're looking at rigorous studies, there's actually only 4 small studies that really look at a limited range of interventions to facilitate transition. And the amount of time that these clinical studies actually looked forward and looked at how effective these interventions was actually quite small. Because if you can imagine, transition is really a process that starts in early adolescence, around the age 12 to 13, and goes well into the mid-20s. So we have to really be focusing on the future and knowing where we're going, so that we can really address our patients' needs as best as possible. So personally, I focus on congenital heart disease and transplant, and in doing so, I also focus on the care of a large population of cardiomyopathy patients that need specific medical interventions and ultimately may need transplant. And some of the research that I do, and I look at sort of national trends and how patients do who particularly have transplant, and we notice that patients who are younger, or sort of as pediatric patients, tend to do really well with transplants. However, patients who are a little bit in that sort of adolescent age, who are between the ages of 13 and 24, actually have a lot more problems with transplant and heart transplant specifically. And that often is due to just that they're risk takers, and they often fall out of care, and then they become difficult with their parents, and then maybe they don't take their medications. Our colleagues in the kidney world also look at whether or not patients are compliant and what happens during transition. And from the time that a patient goes from a pediatric realm to an adult realm, almost 20% of them have chemical signs in their blood panels that show that their kidney function decreased during that really vulnerable time. Now, I'm not telling you this because your child is necessarily heading towards a transplant or a kidney transplant specifically, but it just sort of gives us evidence that this time, this bridge from the pediatrics to the adult side, we call it medicine, it tends to be a really vulnerable time. And whether or not it's any type of chronic medical condition, there's a lot of evidence to support that it's really a vulnerable time, and so that it's really worth our efforts to make sure that everybody gets the individualized and personal care that they need. And you know, I always use this representation of a beautiful modern bridge as the bridge between pediatrics, but far too often that bridge looks more like this, and it ends up having a lot of peril in the way. So I think one of the things that we really also need to start with, that transition is just as important for the parent or the caregiver as it is for the patient. And I'm going to sprinkle a couple quotes throughout our talk that share some of the perspectives of both patients and parents and caregivers in terms of what their experience is as they're going through the transition process. So this is from a 14-year-old patient that I think I met probably about 2 or 3 months into being a faculty member about 10 years ago. And I remember the patient saying something, gosh, I'm just done with all the toys in the waiting room. He said specifically, I can't wait to not have coloring books and toys in the waiting room. I'm ready to be treated like an adult. So some people are really ready a lot earlier than others. I have some patients that, if on my adult side, that if they could still see me in pediatrics, they would. You know, they might be in their 40s, but they would still prefer to be in pediatrics. Whereas I have other patients that when they're 14, 15, they're ready to be on the adult side and they want to be treated like an adult. And then here's, just to juxtapose that, here's a 21-year-old patient who's like reluctant to come over to the adult side. She's saying, gosh, I've known these doctors for my entire life. You know, she was diagnosed with dilated cardiomyopathy when she was 5 years of age. And she had a period where she was on the transplant list, and then she was able to be treated medically and her heart function improved. And then she was then followed very closely, but she's like, how can I trust the people on the other side? And that is really a process when you've known somebody and you've had a long relationship. Now, the other sort of realm that I really focus on is congenital heart disease. As I mentioned earlier, I personally have congenital heart disease. And I wish we had more data about the transitioning process for patients who are going through cardiomyopathy, but I think it's useful to look at some of the studies that have been done. So this is a study that's been done by the Adult Congenital Heart Disease Association. And this is 1,500 patients that are fairly motivated to be part of an organization like the Children's Cardiomyopathy Foundation, who took a survey. And what they found was that over 67% of them had a gap in their care, meaning that they fell out of care for over 3 years after, once they became an adult. Almost 40% of them had a gap in care that was more than 10 years. So that's a huge number of patients who are just being lost to care. And almost 85% of those patients had their first gap in care somewhere between age 18 to 25. So as you can imagine, as maybe patients exert more independence from their parents, they go out on their own, they maybe are under the impression that they don't need to see a cardiologist, that they don't need to stay into care and be followed closely. And as you can see there, I'll just go back with the box, you can see that almost 50% of them had this impression that they never needed to see a cardiologist again. 48% of them, or half of them, actually came back into care, not because they figured, oh, I should just see a cardiologist and get it checked out, because they actually had new symptoms and had an event that actually forced them back into care. And still, of people who were involved in this very great organization, that still 13% of them had no regular care. So as a medical field, we're really, not succeeding in a lot of ways. We're not succeeding in educating people about the need for lifelong care, about the importance of taking care of themselves, and then also not recognizing that during vulnerable periods of our lives that we're more likely to fall out of care. What we do know is that transition does bring improvements, and what we find is that people who have been transitioned and gone through a formal transition process in the medical setting have a higher likelihood of clinical follow-up. They have a higher likelihood of adhering to the therapies that they're recommended. I think there's a cognitive switch that happens late in adolescence where, as a child, you take the medication you take because you're told to take it, and potentially as you go through the transition process, you understand the mechanism of the medication or why the medication is keeping you healthy, and therefore you're able to adhere to your medications a lot better. And with improved adherence, we've been able to demonstrate that you're more likely to have fewer emergency care visits, fewer and lower risk interventions or procedures, fewer what I term medical misadventures, where you're bounced throughout the medical system without much of a purpose. And there's an improved therapeutic alliance so that you and your team are both on the same page of understanding. So that brings me again back to just the quick definition of transition, this purposeful planned process of getting you from pediatrics to medicine. So if you appreciate that pediatrics and internal medicine or the adult care is a slightly different realm of thought, it's a different realm of training, so that people who have dedicated, 7 to 9 years of training in order to take care of patients. They come from very different places or foundations for their understanding for how to interact with patients. Now, there's something called med-peds, and a lot of med-peds are transition champions, and that means that they train over an extended period of time in order to be trained in both pediatric and adult medicine. So I, for example, did the same training. I spent a 4-year period for my general training in rotating back and forth between pediatrics and internal medicine, and then I took boards both in pediatrics and in internal medicine, and therefore I'm board certified both in pediatrics and internal medicine. I subsequently went on and did a pediatric cardiology and adult congenital cardiology fellowship and got board certified in both of those as well. And I can tell you from experience that pediatric care and training is focused on developing relationships with your patients and with the entire family unit. And it's very focused on appropriate developmental milestones and focusing on when those milestones changes and making sure that individuals meet those milestones. With pediatric care, you're also a very family-centered communication. You communicate with the patient or the child based on where they're at. If they're a toddler, you try and speak in terms that they understand, and then as they develop and they become teenagers, you become more sophisticated with your communication in such a way that they understand. But the parents often drive the conversation and drive the implementation of the plan. Pediatric care, I also find, tends to be a little bit more nurturing based. We tend to have more resources in terms of development. We often have nutritionists in our clinics. We have social workers in our clinics. And then we have specialties such as pediatric cardiology or cardiomyopathy clinics that really focus on the entire care of the family. What a lot of people find when they transfer over to the adult side of care is that the interactions tend to be much more cognitive, that internal medicine physicians sort of deliver information that knowledge is empowerment. So if you understand why I'm doing X intervention, you're going to comply because you're on the same page as me. The communication tends to be patient-centered. It tends to be focused on the person who has the condition or the medical issue. So it tends to be more of a one-on-one communication, which for families who have been very invested in the care of the individual or the child throughout their lives often feel sort of cut out. And then in what a lot of adult care is, because adult care tends to be focused on diseases of aging, what they tend to find is that it ends up being focused on declining function or changing function over time versus that developmental acquisition of additional knowledge and skills. Now, the good thing is that, as I mentioned before, there's a lot of benefits to transitional care. It's just very hard to implement. And it really requires medical systems to be focused on delivering these types of care, which are very expensive to provide and very hard to demonstrate to other people in a very short period of time, at least value. So it sometimes gets overlooked. And the other issue oftentimes is that pediatric care, particularly in standalone children's hospitals, are much harder to provide transition of care when you have to actually change geographic location. Now, one of the things that's been really nice for me at a place like UCLA is that our pediatric and adult hospital are in the same place, and there's a lot of integration of services. But if you or your family is at a children's hospital, there are a lot of my colleagues throughout the country who are really focused on doing this well and making sure that there's good connection and good bridges between the pediatric clinics and the adult clinics. Because we've been very good at articulating the importance of transitional care, insurers are now requiring most hospitals and clinics to have formal transition programs and plans. You're probably very aware of U.S. News and World Reports, and they've actually taken interest in transition, and it has become a component for rankings for hospitals. And then CMS is the Center for Medical Sciences, which is the government agency that regulates transplants and cardiomyopathy in this country. And now they're requiring that everybody have transition plans and programs in place in order to be certified and get funding for their institutions. Now, there's a lot of barriers to transitions. There's a lot of everything from, patients being resistant to moving over to the adult side, an inability or difficulty negotiating medical systems, or adolescents relying on their parents to make their appointments, to refill their medications, which can sometimes lead to difficulty making the switch once they become an adult. And then as a medical system, oftentimes we're very poor, as I mentioned earlier, counseling about long-term clinical challenges, what types of challenges you may face, and therefore maybe the individual becomes dismissive of where they really stand. Then there's the practical issues. Sometimes insurance dictates where patients can go, and that can be a real struggle for transition. Now, going back to just some evidence, there's some really good information and surveys out there. This was published in the Journal of American College of Cardiology. And what they found was that a lot of the barriers to transitioning people from the pediatric realm was a parental emotional attachment to the pediatric provider, as well as that patient emotional attachment to that pediatric provider. Kind of like that 21-year-old cardiomyopathy patient that I mentioned earlier, who said, gosh, I've been followed by the same provider my whole life. How am I going to develop, a good relationship? And then the other thing that oftentimes we see is that there's a lack of qualified adult providers in a specific specialty. There's other sort of triggers that cause pediatric specialists to often send patients over to the adult side. A lot of them include things like adult comorbidities or medical problems. Sometimes the pediatric providers just decide, gosh, this patient's too old to be in my clinic. And every pediatric provider has a different line in the sand for that. In the congenital world, pregnancy is often a major reason why patients get abruptly transitioned or transferred over to the adult side. A lot of pediatric providers will continue seeing patients through college graduation. Getting married is often a life event that will provoke pediatric providers to say, okay, it's time for you to head over to the adult side. And then there's just things that sometimes pediatric providers aren't as comfortable dealing with, such as use of alcohol or illicit drugs. And then the smallest number here is the high school graduation. So there are a lot of groups out there that are developing transitional tools. This is a coloring book that's meant for younger individuals that was developed by the Healthy Heart Foundation, and gives some of the patients tools to ask questions and develop ways or thoughts about how to engage their providers. There's also some guidelines out there from the American Heart Association, the International Society for Heart and Lung Transplantation, that really look at evidence-based recommendations and consensus-based recommendations for why transition is so important. So now let's turn to what the parents often sometimes say. They said, when we left pediatric care, it was as if someone flipped the switch and turned the lights off. So I think that really goes back to that difference between family-centered communication and sometimes one-on-one types of communications that people often perceive or feel when they come in to the adult side from pediatrics. And this can be a real struggle for parents, particularly as they transition over to the adult side. And as I mentioned earlier, transition is just important for the parents knowing or feeling confident that their child is ready to take the reins, that there are systems maybe in place to make sure that their child won't fall through the cracks. So let's talk about the specifics of transition. So for me, and for the literature, it really starts early. Really recommend starting as early as age 12 or age 13. It's focused on increasing independence over time. It really needs to have a multidisciplinary type of slant, using the medical provider, using nursing, using social work, using psychiatry or psychology services to make sure that we're doing our best. And then a planned transfer of care to the adult team with a a formal handoff. Now, one of the things that people often get confused about, particularly if you're saying you're starting transition as early as age 13, is to focus on the fact that transition is the process of educating and developing skills, whereas transfer is the actual handoff to the adult side, which is really two different specific entities and processes. And so we really believe that the transition plan needs to integrate the whole family, that every patient is developmentally different, and that somebody may be ready to transition at age 17 or 18, and other patients may be ready to transition or transfer when they're 21 or 22. And we need to be cued in on that and give both the parent and the child the ability, or young adult, the ability to say when they're ready to make that sort of switch over to the adult side, and not force them through a cookie cutter that forces something when it's maybe too early. So, transition really is, again, a process. This is just a nice graphic that puts everything that we talked about together, that it brings everybody together, parents, guardians, pediatric providers, adult providers, making sure that insurance isn't a reason for a gap in care, noticing when there might be high-risk behavior on the part of the patient, and then integrating the whole institution, making sure that patients are ready for transfer, and then making sure that there's a mechanism in place to make sure that some patients don't fall through the gaps. Now, there's a lot of family factors that go into, the transition process, and also, I'm sorry, this is a slide that specifically refers to transplant, but, any chronic illness really transforms the relationship of a parent and child, and it also has really big impacts on siblings and the entire family dynamics. Our parents often struggle with, having, change in expectations when you have a child who has an illness, the sense of guilt and loss, and maybe mourning what may never come for their child. And then there's a lot of, as providers, we really have to recognize that there's a huge amount of time burdens on the whole family, as well as financial burdens, and it often requires families to lean on grandparents and extended family members to provide care for both the patient and also for siblings. The other thing that happens sometimes with chronic illnesses is that parents can change the way that they interact with their child, and it can really change the way that individuals have their normal developmental process of adolescence, of developing independence, of developing life skills that are really fundamental to the long-term process of self-care. I always try and involve siblings within our medical visits, make sure I have an interaction with them as well, because they often feel marginalized, and they can see and feel some of the demands that parents are having to put out for their child with a chronic illness. So this is a 16-year-old a parent who said something, and the parent, it was really profound when she said this. She said, "I realized that so far I spent more effort teaching my child how to cross the street when he was much younger than how to effectively participate in his cardiac care." And I think that there's a desire of parents oftentimes to take the reins, make sure nothing goes wrong. And part of it's, I think, feeling steady, but also making sure that nothing falls through the crack. But it's really important to teach our adolescents how to care for themselves, why we're doing what we're doing, why the medications that they're on are that they're on. I think it's worth thinking about different parenting styles. There's a really lovely book by Diana Baramderd, which looks at the theory of different parenting styles. It's a little clinical in nature, and I think every interaction with children crosses over between all of these different types. And I just kind of bring it up because I think if you think about how you interact with your child, sometimes you can think about how you're interacting with them in order to try and achieve the goal of being a healthy young adult when when that time comes. And so she focuses on, how the parent-child interactions are really impacting the long-term development of the child. And she describes 4 different types of parenting styles. The first 2 are authoritarian and authoritative. And if you're an authoritarian type parent, and again, like there is a lot of fluidity between these, but I think it's helpful to think about these different parenting styles. An authoritarian type parent has really strict rules. They may not have a lot of reasoning in their discussions with their child. They expect obedience and they have a lot of high demands. And a lot of times these children have display obedience, but they tend to not have the same levels of happiness as a lot of other children. Authoritative parents tend to be a little bit more democratic. They're responsive and available. While they have clear expectations, they are provided in a nurturing and forgiving way, and that there's clear standards, and that there's an assertion what's appropriate, but there's not necessarily always intrusive. And what this specific author, who is again very wonderful, she describes these children as developing more capable type of attributes, and they tend to be more successful. The other 2 you can imagine are permissive parenting styles, where there's low expectations. They avoid confrontation, and these children often develop problems with authority. They have more difficulty with self-regulation. And then there are some parents who withdraw. They tend to have few demands. They are a little detached, and the impact on child development tends to be poor self-control and low self-esteem. So I don't bring this up so that you analyze the way that you interact with your child, but I think that maybe you think about how different types of strategies and the way that you parent, particularly as you're going through the transition process, may benefit your child's development. So how do we bring this bridge together, and how do we allow our patients and our young adolescents and young adults bridge the gap between the pediatric realm and the adult side? So for parents, what we hope to encourage is that to teach and give your child the space to take ownership for their health in a very safe way. That means encouraging them to ask questions, giving them space to speak to doctors, nurses, social workers, and psychologists on their own, and not to expect them to take all the responsibility all at once, but in a stepwise fashion, in such a way that they can really succeed. Now, in patients, we try and encourage them to know your medical condition, to understand it, to be able to explain to an emergency room doctor that may know nothing about cardiomyopathy, and be able to advocate and at least communicate at first about themselves and their needs. And then to know their medications, to know the name, the dose, why they take each medication, and what it does to keep them healthy. And then to know to ask questions and to be able to express if they're having any side effects. And then slowly over time, making their own appointments and calling for medication refills can be really helpful as well. Now, just to turn back to development, pediatrics, we focus on development all the time, and we think about different stages of development. And just to give you a couple tools to sort of appreciate why transition is a process and how the developing young brain of an adolescent sort of works. So when you're between age 10 to 13, your cognitive reasoning tends to be very concrete. You tend to have same-sex peers, and then the early sort of process of independence develops, and then the early adolescent patients tend to test their parental values. And really, this is where you develop the foundation for transitional care. You kind of explain what it is. We focus on making sure that this is not a foreign concept, that we're not just kicking you over to the adult side when you turn 18. And we really need to focus on some of the physical development, sexual development, and then making sure that we're really addressing substance use very early, and then making sure that social structures are intact and are being developed in healthy ways. Now, as you move into middle adolescence between age 14 and 16, patients tend to move from being concrete to being more abstract in their ability to think sophisticatedly. You start to develop more relationships and peers that are of both genders. And then from an independent situation, 14 to 16-year-olds tend to express a little bit more ambivalence about separation from their parents, and from a value standpoint, they tend to be a little bit more self-centered. It's really the best opportunity to influence future high-risk behavior, things like risk-taking, use of illicit substances, and alcohol use. It's important to start addressing sexual and reproductive issues, appropriate athletics, and then being safe. And this is a good time to start encouraging medical independence. And finally, you have late adolescence, where this is the 17 to 21-year-old on average, where you start to have a little bit more abstract thinking. You have slightly more individual relationships. You start to integrate more desire and push for independence, and then you start to establish your moral compass per se. And again, these are great times to focus on, making sure that family planning issues are taken care of. If you are female, whether or not you have contraceptive options or cycle regulation options, making sure that there may not be a gap in insurance issues. Here in California, we have something called CCS, or California Children's Services, that a lot of children who have chronic healthcare problems are taken care of by the specific type of insurance, but that runs out at age 21, and you have to have a good plan so that you don't have a gap in care. And then planning for either college or vocational planning, and then making sure that healthy behaviors such as exercise and good dietary habits are developed, and then setting the foundation for further independence. I can't stress enough the importance of talking and speaking early about whether or not there's a desire to go on to college or if vocational school would be appropriate, and then appropriate work choices. I can't tell you the number of cardiomyopathy patients who come in and I want to be a construction worker who works on, high type construction projects, or I want to be somebody who's like an emergency medical technician lifting patients from one place to another, and really setting realistic expectations so that it protects their health and also sets them up potentially to have a productive job where they can get health insurance provided for as a really important thing. Now, sort of piggybacking on all those things and what we expect patients and parents to do, there are published checklists out there that we use in our clinic that looks at every different age, saying that we do sort of basically a checklist. Do you know your medication? Do you know how to get your labs? Do you know how to make your own appointments? Have you talked to your pediatrician about your reproductive cycles? And all these different sort of factors to make sure that every patient has a good plan once they go over. In the cardiomyopathy and transition realm, we also have a formal transition day where we meet and greet with the adult team. What we do in the beginning is we have a formal sign out where we describe the particular condition that the patient has, the journey that we have taken over the years before they transition over to the adult side, so that the entire adult team, everybody from social work to the doctors, all have a sense of what the patient has gone through, and then they can actually meet some of the adult team members, bond with other families who are going through transition at the same time and are getting ready for transfer. What we do on this specific clinic day is we also have half of our patients go and take a tour of the adult clinic, and then the other half is having a regular clinic appointment, and then they flip-flop and they go on the tour, and then the other patient has their regular clinics. So there are just a few tools I wanted to describe in the last few minutes of our webinar before we open it up to questions. Teenagers tend to be super plugged into technology, so giving them access and giving them autonomy with some of their medical records can be a really great thing. Here's an example where I've made my home screen, and I show this to my patients as an example. I've made a home screen of my medical condition and then some emergency contacts. There's also, most medical systems have a specific type of medical software that they keep their medical records in. The big two are something called Epic, and the other one is called Cerna. And then each medical system sort of labels their type of medical record system with their own sort of fancy term. At UCLA, we call it My UCLA Health, and this gives patients access to their own medical records and their own labs and their medications. And also you have the ability through this app to reorder medications and cancel and change appointments. If your child takes a lot of medications, or if you're a patient who's on the line, there are good tools out there for remembering medications. This specific app is quite nice. It's called MedCoach. You can put in your medications and you can say when it's due, and then you can click it off as you take each medication. There's also a feature within the app, or at least there was the most recent time that I took a look at it, where you can have a backup person where the app will notify a buddy about if you are more than 30 minutes late from taking a medication. So you could set a parent as somebody who gets a text message if you haven't taken your medications. The one caveat is that it's very easy just to silence the app by checking it and not necessarily taking the medication. So there's definitely a trust factor there. It's always worth kind of mentioning in the last few minutes, insurance as well. You know, maintenance of insurance is one of the most important things. One of the best things about the Affordable Care Act is that individuals who are younger can stay on their parents' insurance until the age of 26. Some patients with more chronic conditions qualify for Medicare or Medi-Cal, but there's often specific requirements to stay within those types of medical care insurances. There are several types of jobs out there that even if you're a part-time employee, such as at Starbucks and Jamba Juice and a few others, that you can get full medical benefits if you're a part-time employee there, which is another good way. And then oftentimes people who are full-time students can get access to healthcare insurance at a cheaper rate through the Student Health Insurance Program. And then going back again to the Affordable Care Act, each state has a mechanism to buy insurance that can be subsidized based on your salary. Another thing that I always bring up in all of my transition visits with my patients is the value of travel insurance, particularly if you plan on moving more than 150 miles away from home. There are several different types of travel insurances out there that have modest expenses. So whenever you go on a vacation, I think it makes a lot of sense to buy one of these insurances. They usually provide up to $50,000 of emergency medical evacuation insurance should you require it. A lot of, even if you have insurance and say you're away at college more than 150 miles away, you may have significant expenses for an acute hospitalization if it's provided out of network. And so some of these types of services, specifically MedJet Assist, provides medical evacuation anytime you're 150 miles from home. And MedJet Assist, I think, costs about $250 per year. So it can really provide some peace of mind in situations when you're outside of your medical systems area. Just to kind of throw out that there's a lot of issues out there, from pregnancy to use of energy drinks to not so illicit substances to illicit substances. And then just a quick plug for something that we do locally here in California. There's a nonprofit organization called Camp Del Corazon, which provides a medically supervised camp experience in Catalina for children aged 7 to 17 with any heart problems. So it is free of charge and is really a wonderful 5-day experience out in Catalina. There are similar camps throughout the country, which I think also helps children who have chronic medical conditions like cardiomyopathy relate to other children who are having similar issues, particularly in the teenage years. It's a good way to realize that you're not alone. Now, Camp Del Corazon has been in existence for 25 years. We just had our 25th year this past August. And about 10, 15 years ago, they formalized a program called PACE, which stands for Progressive Adult Cardiac Experience. And this is a weekend event over Memorial Day weekend where about 70 to 80 young adults with cardiac issues come together and seek fellowship and companionship. But they also do presentations where they talk about, maybe some of the 25-year-olds talk about how they got into college or what kind of job they got or were able to get, and how they disclosed their medical conditions to their employees or how they didn't disclose that. They also ask for experts to come in and talk about insurability issues, how to deal with anxiety and depression. And then there's a lot of socialization, which I think is really fun and really good. I know that there are PACE programs that are starting to pop up throughout the country. I know that there's a new one that just opened up in Nevada, and I think there's one also in Florida. So something to think about, and a really neat program. And I love what one of these campers put on the trailer that you just saw there. Normal hearts are boring, which is it. These are some of the, I go to all these camps, and it's really the non-medical things that sometimes brings some of the most joy to my career and to my life. So with that, we'll sort of open it up to your questions, and thank you so much for your attention.
Thank you, Dr. Reardon. So if anyone has any questions that they would like to ask specifically from Dr. Reardon, you can always type it into the question box in the chat window, and I will read them out. I do have a question that one of our families who could not be here tonight but asked me to ask this of you, Dr. Reardon. She said, my question has to do with letting my child make their own decision as they become adults. My child has lived their entire life with their disease and has some very strong opinions related to their care. And when he becomes an adult, I understand that this is his right. But as a parent, I'm having a tough time accepting this and pushing my feelings, which oftentimes only backfires. Do you have any suggestions or thoughts about dealing with the emotional part of letting your child go and letting them move on and become independent?
Well, I think that what they're describing in terms of their child having strong opinions is also an assertion of independence and autonomy, which I think is something to be appreciated. But there's certainly healthy ways to assert your independence and your own autonomy, and unhealthy types. I think that most providers are pretty cued in to some of the challenges, and I can tell you that most people wouldn't be surprised by the type of challenge you face. So you may want to reach out to the provider before a visit, like the doctor before a visit, and explain what you're feeling, and then maybe set it up so that you can give your child some space with the provider or physician or professional alone so that they can work through things. If your child is over the age of 18, they may not be able to disclose the full range of the discussion there, but if they're under the age of 18, then they may be able to circle back around and give you some strategies that are specific to your child and what types of things, or maybe they'll suggest having more frequent appointments so that they can help process things. Our cardiomyopathy clinic is very fortunate to have a full-time psychologist that works with us. and she has support groups, and she has the ability to intervene and do web-based telesessions to help with these specific types of struggles.
Okay. All right. I have another question. We don't have a formal transition program at my child's hospital. What is the best way to find an adult cardiologist who specializes in your child's specific cardiac issues?
So I think the first place I would start was with your provider and say, hey, we're getting to age 18 or whatever age you're there, and it's, when do you think we should transfer? When do you think we should transition? Do you have recommendations? And then I would reach out to your community. And in reality, most people who take care of cardiomyopathy patients also take care of transplant patients. So I would look at your closest transplant centers and start looking through the bios of, some of the individuals who are practicing in those centers. Many people who are interested in younger patients in the adolescent mind tend to say specifically in their profiles that they specialize in adolescent medicine or transitional care.
Okay, great, thank you. And then last question is, what questions should a parent ask an adult cardiologist?
Ooh, so that's a good question. I guess it sort of maybe they could clarify as I'm giving sort of my sort of thoughts about if they want to clarify about transition or whatever. But for me, if I was starting with an adult cardiologist right away, I would want sort of a fresh look at my child, and I would want my child to have some autonomy and also have some interaction with that provider on their own. But I would want a fresh look, sort of, can you explain to me what the condition is? Can you explain to me some of the challenges that we may see in the future, and how are we going to manage those challenges? I think are really important. And then maybe also engaging and saying, is there a way, if I'm worried about if my child is following up, that I can reach out to you, and that, either a nurse or you can reach out to my child if maybe there's non-adherence or there's some sort of concern there that maybe you don't want to intervene too much with your child directly if that's a tense sort of discussion.
Okay, great.
I don't know if I answered that very well, but
well,
is there any follow-up from them?
No, I don't have a follow-up, but so I think you got it. So at this point, we don't have any other questions. I want to thank you so much, Dr. Reardon, for sharing your time and your expertise. This was really informative, and I really appreciate that you gave us this very informative webinar today. So I at this point, we have formally concluded the webinar, but I just want to mention a couple of other things. For those that are in the audience that are not familiar with Children's Cardiomyopathy Foundation, we encourage you to go to our website to learn more about our organization and the resources that we provide. Our website is www.childrenscardiomyopathy.org, and Children's Cardiomyopathy is all one word. Just also want to remind everybody that September is Cardiomyopathy Awareness Month, so please visit our website for activities, including our Walk for a Cure, which is coming up this Sunday, September 29th, which is going to be in the New Jersey area. But if you're not in New Jersey, we have lots of families and people that are doing hometown walks across the country. And I just want to remind everybody that today's webinar will be available on our YouTube channel, CCF Heart Kids. And that is it. I want to thank everybody for joining us, and I really appreciate that you gave your time. Thanks, Dr. Reardon.
Thank you so much. Take care.
All right. Bye-bye.
Bye-bye.